Class, I'm going to now talk about the meds that were in your weekly lesson plan that I want you to review and understand what action occurs when patients are ordered these, and to correlate these meds with the pathophysiology that you're getting from your Nursing 122 lecture. I'm going to start off with the anti-epileptic drugs, anti-anxiety drugs, and some of the skeletal muscle relaxants, okay? Some of the drugs you might see ordered for patients who develop seizures, okay? And the first drug I want to talk about is diazepam, all right? Diazepam is a anti-seizure drug. It's a benzodiazepine, pharmacologically classified. It's a GABA and a receptor agonist. It's used for patients who suffer from seizures. The primary indication for diazepam is a status epilepticus. And it also may be used to prevent seizures in patients who have received toxic substances or during the acute phase of an alcohol or benzodiazepine withdrawal. And a lot of times we do give Valium to our patients, or diazepam to our patients who are coming off from an intoxication, acute intoxication. Remember, diazepam binds to the GABA receptor chloride channels throughout this central nervous system, and how it produces the effects that we hopefully see the patient obtain from this medication is it suppresses neuronal activity in the limbic system and subsequent impulses that might be transmitted to the reticular activating system. We can give this drug orally, and we can also give it IV route as well, okay? When we give it to a patient orally, it might take about 1 to 2 weeks before we see the maximum effects from the drug, and tolerance may develop after about 4 weeks. When given IV, the effect from diazepam may occur in minutes, and when it's used as an anticonvulsant, it may last about the effects last about 20 minutes. Again, because it affects the central nervous system, you definitely want to, especially when administering it IV, you want to monitor respirations every 5 to 15 minutes and have a lot of that equipment available for resuscitation, especially respiratory resuscitation and airway. A lot of times we use diazepam for a pre-medication prior to a medical procedure. Okay, it's metabolized in the liver, excreted in the urine. And when you're on this for a long period of time, it may lead to physical and psychological dependence. And that's why when a patient is going to be stop taking, when they're not going to be ordered this drug any longer, especially if they've been on it for a while, abrupt termination of the drug can cause withdrawal symptoms such as a headache, confusion, irritability, insomnia, and restlessness. And if a patient has pre-existing depression or any suicidal tendencies, it may worsen when they take diazepam. Now remember, the important thing is to monitor their respiratory function, blood pressure, and heart rate. But really, especially for the first time, you really want to monitor when they get up and ambulate, to especially watch their gait and make sure they're not unsteady when they're walking, because we don't want a patient falling and hurting themselves or breaking anything. And then assess their level of consciousness for any type of confusion as well. And because of tolerance and dependency, we really want to use diazepam for short-term seizure control, or even for a situation where they develop status epilepticus. Remember, when it is given IV, we always worry about blood pressure dropping, so we do monitor them for hypotension, muscular weakness, tachycardia, and of course watching their respiratory status as well. When giving it in an IV form, be sure that it's not given when a patient could be in shock. They're in a coma, because you can't really assess their level of consciousness, or if their vital signs are kind of in critical levels. And any obstetrical patient and infants that are less than 30 days of age. And when we're giving the oral dose, it should not be given to infants less than 6 months of age, and also to patients with acute narrow angle glaucoma or untreated open angle glaucoma, or within 14 days of a monoamine oxidase inhibitor, an MOA therapy. It's obviously not a good idea to give this medication to somebody that has been drinking excessive amounts of alcohol or any other CNS depressants, because it will further sedate the patients, really putting them into a serious state of respiratory depression. Diazepam will also increase the levels of phenytoin in the bloodstream and may also cause phenytoin toxicity, and I'm going to talk about phenytoin in just a little bit, okay? Herbals, be careful of patients who take herbal supplements such as kava, valerian, and chamomile. They increase sedation as well. If an overdose occurs, your book does talk about administering flumazenil, a specific benzodiazepine receptor antagonist, to reverse the CNS depression. Okay, so that's diazepam as well. All right. Also, our next drug is alprazolam, which we may know better as Xanax, which is an anti-anxiety disorder. And we also see it used sometimes for patients that have problems with sleeping, where they have problems with insomnia, and definitely for patients that have a lot of anxiety as well. All right, the next drug I want to talk about is phenytoin, which is therapeutically used as an anti-epileptic, and pharmacologically it's a hydrantone or neuronal sodium channel modulator. It's used for seizures, except absence seizures, which you have to know what an absence seizure is. Sometimes we refer those as to petit mal seizures. They may prevent seizure. This is maybe used in patients who are pregnant, women who are pregnant that may be suffering from eclampsia. And so this drug may be given to the woman to prevent her from seizing during her eclampsia stage. Also may be given during neurosurgery to prevent irritation and set off some type of excitability in the brain, causing a patient to seizure. General convulsions during status epilepticus can also be used for patients that have VTAC due to digoxin, probably digoxin toxicity, and also used for a paroxysmal tachycardia. May also be used for migraines, diabetic neuropathies, and for neuropathic pain. And how phenytoin works is it acts by desensitizing sodium channels in the central nervous system and prevents the spread of those abnormal electrical charges in the brain that produce seizures. It really is effective against most types of seizures, again, as I said, except for absent seizures. When you're giving this medication, which can be given IV and also PO, when administering IV mixed with saline only, and infused at the maximum rate of 50 milligrams per minute, and mixing with any other medications or any dextrose solutions can actually produce precipitate. Okay, so always prime or flush IV lines with saline before hanging phenytoin as a piggyback, because traces of dextrose solution in an existing IV or a piggyback line can cause microscopic precipitate formation, which becomes an emboli in the circulatory system. Okay, and make sure that they always use an inline filter when giving it as such. When you're giving phenytoin injectable into a soft tissue, it can cause local tissue damage following extravasation. To reduce the risk of soft tissue damage, do not give it IM. So that's really not the recommended route to give phenytoin. Obviously, this drug is going to have adverse effects on the central nervous system, which could cause nystagmus, confusion, ataxia, coma, seizures, and bradycardia. The black box warning with phenytoin is when getting patients, when giving it to them IV form, it can cause hypotension and dysrhythmias. Okay. Use cautiously with anyone who's also getting corticosteroids, warfarin, oral contraceptives, as they actually decrease their effectiveness. And again, anytime we're giving something that affects the CNS, make sure patients are not drinking alcohol. Folic acid, calcium, vitamin D decrease the absorption of phenytoin, and ginkgo decreases anti-seizure effectiveness. So make sure we are aware, or you know, of any of the herbal supplements your patients may be taking. Okay. If a patient should accidentally overdose on this, there's really no specific treatment. A lot of times, if we catch them early enough, we can do gastric lavage on the patient or use of activated charcoal or laxative. So that's phenytoin, or what we know commonly as Dilantin. All right, the next drug that I want to talk about is carbamazepine, or also known as Tegretol. It's also an anti-epileptic. It's a diphenoxazepine, a neuronal sodium channel modulator as well. This drug, carbamazepine, is for generalized tonic-clonic and partial seizures with complex symptomatology and mixed seizures. It's not used for absence seizures. We might also see it prescribed for patients who have acute mania associated with bipolar. It can also be used for treatment of pain associated with trigeminal neuralgia and neuropathic pain, and also for really serious hiccups as well, and for patients that have dementia that become very aggressive and agitated. It inhibits those sodium channels, blocking the repetitive, sustained firing of neurons that is very characteristic of someone who has epilepsy. Again, has CNS effects such as drowsiness, dizziness, ataxia, nausea and vomiting, myalgia, and leg cramps. Can also cause heart block as well. The black box warning with carbamazepine is some of the blood dyscrasias such as aplastic anemia or granulocytosis, and even that fatal skin reaction such as epidermal necrosis and CJS. Other than that, obviously learning about the patient's seizure history, looking at your patient's liver and renal function, looking at liver enzymes, creatinine levels, and really knowing what your patient's vital signs are. Overdose, you would treat with activated charcoal or with gastric lavage. So that's carbamazepine. Okay. The next drug I want to talk about is gabapentin. Gabapentin is an anti-epileptic drug. It's a GABA analog, also known as Neurontin, used to control partial seizures and to treat post-therapeutic neuralgia and restless leg syndrome, neuropathic pain, hot flashes, and ALS, which is amyotrophic lateral sclerosis, also used for trigeminal neuralgia, paresthesia, spasticity, and ocular ataxia in patients who have multiple sclerosis, and you might see it ordered for migraines as well. Really, the action is unknown, but it does not bind to GABA receptors or to prevent endogenous GABA from binding. It does not bind to neurotransmitters such as serotonin, dopamine, glutamine, and histamines. Likely affects the calcium channels, but not really sure how. Again, CNS symptoms, fatigue, drowsiness, nystagmus, dizziness. Patients may have more increased frequency of developing viral infections, weight gain, and gastric upset. Do not stop this drug abruptly. They should be titrated off. And be careful when you're giving this along with patients who are on any kind of opiates such as morphine and hydrocodone. Ginkgo decreases the anticonvulsant effects. So, got to be careful of these herbs that patients may take as well. Again, knowing their history and things like that. Should not be used if pregnant or even breastfeeding. Okay. If this is given to pediatric patients, we notice that some of the adverse effects could be hostility, emotional lability, and impaired cognition, and aggressiveness and hyperkinesis, such as muscle spasms. So that's gabapentin. All right. The next drug that I want to talk about is valproic acid, or commonly known as Depakote, or Debakine. It is anti-epileptic or anti-seizure medication, and it is also a GABA agonist to treat epilepsy. We see it ordered for preventing migraines, to prevent mania in someone who's diagnosed with bipolar, or used for severe behavioral issues in patients who have dementia or Alzheimer's because of their attitude of agitation and explosive tempers. Also used for persistent hiccups and for status as epilepticus. All right. How it works is it increases the concentrations of the inhibitory neurotransmitter GABA that's in the brain, and abnormal neuron discharges are suppressed, leading to decreased seizures. And again, CNS symptoms such as headache, tremors, dizziness, and sedation. Sometimes we see more GI problems with this drug, such as nausea and vomiting, diarrhea, abdominal pain, and even developing a decreased appetite. We worry about decreased platelet aggregation, prolonged bleeding, and clotting times. It may unfortunately cause bone marrow depression. It can cause severe hepatotoxicity in patients that are under 2 years of age as well. Should not be used if they're taking alcohol. Any of these seizure medications, they shouldn't be drinking alcohol with it. Overdose, we worry about oversedation, can cause heart block and coma. You might give Narcan or also do hemodialysis on the patient. But the big thing is to look for bone marrow depression, which will affect platelets and make the patient more at risk for bleeding and delaying clotting times as well. I'm just looking in your book to see if there's anything The black box warning from your book says it may result in fatal hepatic failure, especially under the age of 2 years of age, and that's what I told you about, okay? The one thing with valproic acid, it does interact with many drugs. For example, aspirin, cimetidine, chlorpromazine, erythromycin, and even some of, they can increase the toxicity of this drug. So you'll want to just make sure, maybe you check with a pharmacist to make sure it's safe to give this patient if he's unfortunately suffering from seizures. All right. All right, so that's pretty much all the medications for seizure treatments. So along with learning about the different types of seizures, you're also going to get lecture on the very, very important disease process of diabetes, okay? So that's where our focus is on now, is to look at all our different types of insulin and then to look at the anti-diabetic medications. Diabetes is a very complex disease. It's more than just having high blood sugar. A lot of things are affected metabolically when your patients do have diabetes, okay? So it's very important to understand the pathophysiology associated with diabetes, particularly knowing the difference between type 1 versus type 2. And really knowing that so much of what we do in our life does affect our blood sugar. That's why as nurses we have to do very thorough teaching on our patients with diabetes to explain to them about their medications, about doing self-checks on themselves 4 times a day, just like we do in the hospital, meaning what is their blood sugar, self-testing before meals and at bedtime, knowing signs of hypo and hyperglycemia, knowing what to do when they're ill and maybe they can't take their oral meds, or what do they do about their doses of insulin when they're sick, exercise, stress. Obviously, diet has a huge impact on one's blood sugar. So there's so much that affects diabetes, and plus there's so much to learn as a person who develops diabetes about how to keep that blood glucose within control, because we know from being nurses, at least myself, who's been a nurse a long time, has seen some of the unfortunate complications that occur. How these patients with uncontrolled blood sugars will be at 5 to 10 times more at risk for cardiovascular problems, as well as renal problems, eye disorders, retinopathies. So this is why it's so important that really they understand, just how they are with their blood sugar, depending on whether or not they're type 1 or type 2, and really understanding how all these different types of insulin work, okay? So I'm going to review all these insulins, and again, the table that we're going to go learn from as to onset, peak, and duration, which is what you as a nurse should know every time you administer insulin, and to be able to correctly use proper form when injecting insulin. There's no oral insulin out there because unfortunately it gets consumed by the GI tract, so we have to deliver insulin through injections, okay? And we know insulin will then hopefully lower that blood glucose, okay? And take it within the cell. So please know that all the onset, peak, and duration of these insulins come from the table on page 716 in your Adams book, which is also table 45.1. So I'm going to go through these insulins and kind of explain to you how they work. But these are ordered can be ordered for both type 1 and type 2. Obviously, your type 1s have no pancreatic function at all, so they will be totally dependent on their insulin. And remember that for a type 1 diabetic, insulin is their lifeline. They need to maintain life and to be able to have a fairly productive life. But they also need to take the responsibility of understanding how these insulins work in relation to when they eat, and what insulins are used for mealtime, and what we give in the morning or maybe at evening, and that to obviously recognize early signs of hypoglycemia, because hypoglycemia is a serious occurrence with patients who are diabetics, and this can be a definite side effect from any of these meds that we prescribe for our patients, because anytime we're giving a medication to lower blood sugars, there's always the potential for it to go too low, and then we have to treat that, because you can die from hypoglycemia. It is a medical or a diabetic emergency. All right, so let's go through these different types of insulin. All right, insulin aspart is, you might also know it as Novolog. It's a rapid type of insulin. Onset is usually within 15 minutes. The peak is in about 1 to 3 hours, and it lasts for only about 3 to 5 hours. This is the insulin that you would see ordered for a sliding scale, depending on before the patient eats his meal, getting an AccuCheck on the patient, and then determining what that blood sugar is, and then covering them with this particular type of insulin. It's an anti-diabetic drug, and it's a short-acting hypoglycemic drug. Very similar to endogenous insulin. Make sure that when you cover that patient, depending on what their blood sugar is, that you give it about 5 to 10 minutes prior to meal, and you can mix this with intermittent or any long-acting insulin as well. And again, the key to keeping blood sugars under control is to be sure that the patient is self-testing 4 times a day, just like we do in the hospital. And again, because a patient, whether or not they're a newly diagnosed diabetic or somebody that's been a diabetic for many years, maybe as a nurse you should assess the injection sites, and again continuously assessing your patients as to how much knowledge they have about their diabetes. And then if blood sugars are extremely high, maybe we need to make some adjustments, especially if we look back. And what I like to do when I was taking care of my patients, and I knew that they were diabetic, I would definitely look at, especially if they've been a patient for in the hospital for a few days, I would look at their trend of what their blood sugars had been running. And if I saw any type of outlier results, I would want to say to myself, why was that blood sugar real low that day, or why was it that high that day? Maybe there was some particular reason. So again, if we see a very high blood sugar, we might want to assess the urine, because we want to be sure that they're not spilling ketones and that they're not in danger of developing what we call diabetic ketoacidosis, which you're going to learn in your lecture. Okay, so that's insulin aspart, very rapid onset. The next one is regular insulin, and this is a short-acting insulin where onset is 30 to 60 minutes, peak is in 2 to 4 hours, and it lasts for about 5 to 8 hours. Again, an anti-diabetic drug. Again, regular insulin is usually the drug or the insulin that we choose if the patients do come in diabetic ketoacidosis. Maybe their blood sugars are extremely high and the patients are going to be on an insulin drip. This is the type of insulin that we would definitely see in the IV bag. Other than that, just knowing the onset, the peak, and the duration. And this would also be another prandial insulin used for sliding scale. You might see the physician ordered this one as well to cover a patient during mealtime. All right, so that's regular insulin. This is a short acting, okay? The next insulin that I want to talk about is NPH. Okay, NPH is, you might also hear it called isophane. It's the only intermediated insulin. Onset is 1 to 2 hours, peak is in 4 to 12, and the duration lasts up to 18 to 24 hours. This is also a cloudy insulin, which is normal for this insulin to be cloudy, whereas your insulin aspart and your regular are clear insulins. And that's why it's important that you review those ATI videos on insulin and insulin syringes, because they talk to you about the characteristics of some of these insulins. And it's important that before you administer these insulins, that as you find it in the vial, that you definitely look at that vial and make sure, should this insulin be cloudy, should it be clear, and then if it needs to be mixed, you need to just roll it gently in between your hands. This is a neutral pH suspension of crystalline zinc insulin. That's definitely combined. That's definitely a combined insulin. And many times, to better control your patient's blood sugar, say for instance, if we're not really good, steady blood sugars across the day or during the day, that you may want to add this type of an insulin where you might want to give it in the morning, and you can mix this with some of your rapid or your short-acting insulins, and then we'll kind of watch them for a couple weeks to see if that extra insulin added to their medication regimen helps to keep those blood glucoses within more of a steady control. Then maybe we could also give this a second dose, which could be possibly given in the evening as well. All right, so that's kind of how this works with insulin. Now remember, as I said before, your type 1s are going to be strictly on insulin. Now, not necessarily for your type 2s. We may start them on, which I'm going to talk about in just a short time, with the anti-diabetic oral meds. And I'll go over those different classifications of those as well. We start them on oral meds first, and sometimes we also encourage them to maybe make some changes in their lifestyle, losing weight, and maybe their blood sugars can be more controlled by diet as well. And then we'll put them on an oral anti-diabetic med. We'll start them on one, and then we'll watch them for a few weeks to see how their blood sugars go. That's why self-testing 4 times a day is so important, and kind of keeping track of calories. That's why this is such a huge part of the education that we need to provide for the diabetic patient. So, we kind of have to have a food record of what they're eating to be sure that they're intaking enough protein and carbohydrates in a certain percentage of where their calories should come from. And then, of course, making sure they have good fiber in their diet, and, of course, proper hydration as well. So that pretty much is all the insulins, because we talked about Glargine in week 1, so I'm not going to go over that one again. But now we're coming to our anti-diabetic oral drugs, And as I said before, these are given for type 2s. And what they'll do is they'll put him on one and then watch him for a couple weeks. And then what they'll do is add a second one from a different classification. And then, say for instance, this patient is not stable, they'll add a third one, but again from a different classification. Usually after 3 meds, if the patient is still not very well controlled, then that's when they might put them on some insulin as well. So you will see possibly a type 2 who's very hard to control with just the oral meds, maybe put on insulin as well. So let's go over these particular drugs so that we can kind of learn about a prototype from each of the different classifications of anti-diabetic medications. Okay, the first classification, and I have this PowerPoint up here, is for your type 2 diabetics. And let's talk first about your sulfonylureas. All right. And our prototype for this classification is glyburide. And of course what it does is it lowers blood sugar and for our type 2 diabetics. And how this particular drug works is it stimulates the release of insulin from pancreatic beta cells and increases the sensitivity of peripheral tissues to insulin. Now, because we're lowering blood sugar, the big side effect that we watch for is hypoglycemia. Sometimes you see patients develop a little bit of GI distress, such as heartburn. They may also have photosensitivity and blurred vision. But for the most part, patients do tolerate this sulfonylurea fairly well. Extreme adverse reactions might be aplastic anemia, leukopenia, and thrombocytopenia, which obviously affect the bone marrow and the cells that come from that. Now, with any of these medications, especially when patients first start on them, we should know what their blood sugars are, okay, and have be sure that we assess the learning and education with the patient in regards to their diet, knowledge on their diet, dosing, and any other aspects of their disease process. They should not use this with sulfa or thiazide diuretics. Use very cautiously in patients, in liver patients, due to possible toxicity, and should stop 1 month prior to the delivery of a newborn. And again, do not use with some of these herbs such as ginseng, garlic, black goat cohosh, juniper berries, coriander, and dandelion root. So that's the prototype from your sulfonylureas and any type of hypersensitivity to any of your sulfas. Some of your antibiotics that treat infections, you might be given a sulfa pill. If they've had any allergic response to that, you would not use this classification of anti-diabetic meds such as a sulfonylurea. All right, your next classification of meds is your meglitinides, and that would be, your meglitinides, and the prototype for this is repaglinide. All right. Again, it lowers blood glucose by stimulating the release of insulin from the pancreatic beta cells. So it kind of says to the pancreas, hey, it gives it a little push and says we need a little bit more insulin. And again, we worry about hypoglycemia. Patients should know their blood glucose for that day or before they begin, before they take these. Use cautiously in meds that inhibit hepatic CYP3A4 enzyme. Be careful if they're taking this with NPH insulin as well. It is known to cause MIs, and do not take with grapefruit, garlic, or ginseng. All right. Vomiting and diarrhea and some of your GI problems like dyspepsia, headache, paresthesia, and more prone to upper respiratory infections, sinusitis, rhinitis, and bronchitis. So that's repaglinide, which is a meglonide. Okay, that's another classification of anti-diabetic medications. All right. The next one is your TZDs, or your thiazolidines, which are drug prototype for that one is rosiglitazone. All right. So, and I just call it TZDs because that's a really long word to say. Okay. So again, we're talking about the classification of thiazolidinediones, okay, and I just refer to as TZDs. And our prototype for this particular classification of anti-diabetic meds is rosiglitazone. Okay, it lowers blood sugar in our type 2 patients by increasing cellular sensitivity to insulin, therefore reducing insulin resistance. Of course, hypoglycemia is our main concern. This drug a few years ago was taken off the market because unfortunately a cardiac patient used it, and they ended up having an MI and dying. But this is what the black box warning is. It can worsen heart failure and increase the patient's risk of developing an MI. So do not use if a patient has a bad liver, with heart failure, pregnancy, lactation. It may also cause macular edema, anemia, headaches, back pain, fatigue, and diarrhea, and many of those upper respiratory infections as well. Because it can have an effect on the liver, what they do is before they begin this particular drug, they will assess liver function in the beginning and do liver enzymes, and then every 3 to 6 months just to make sure the patient is tolerating it okay. So again, these are your thiazolidinediones, or your TZDs, and our prototype is rosiglitazone, and or also known as Avandia. All right, and then our last classification is your biguanide. And this is probably one of the most common and most familiar anti-diabetic meds from this classification, and you might know it as metformin or glucophage. It is a drug that's pretty safe. This is usually what they'll start the patient on, is metformin. It can be used in children 10 years or older, and what it does is it actually decreases the hepatic production of glucose and gluconeogenesis and decreases insulin resistance. And the good thing about this is it does not cause hypoglycemia, and it also has an effect of decreasing triglycerides and LDH, and also sometimes when patients start on this, it can promote weight loss as well. The adverse reaction to, some of the adverse reactions to metformin is lactic acidosis. Some patients also develop a lot of gas or flatulence and diarrhea and abdominal pain. And many times patients will complain when they take this that they have a bitter or metallic taste in their mouth. Obviously contraindicated in patients who have impaired renal problems or CHF, liver failure, or also have a history of developing lactic acidosis. Also contraindicated in patients who are getting any kind of dye for a diagnostic procedure. If they're on metformin, they'll discontinue it 48 hours before the procedure to prevent the chances of them developing lactic acidosis. And then even after they come back to their unit, and they'll wait another 48 hours before resuming the med. And a lot of times off the label to treat, this drug is used to treat polycystic ovary syndrome, and even women who have insulin resistance and high serum insulin levels. It'll decrease androgen levels and decrease insulin levels as well. So that's metformin, which is in the classification of a biguanide. All right, and you can see too that there's this PowerPoint that's in your Canvas course as well that talks about some of these anti-diabetic drugs and their actions. And you can see that your thiazolidiniones, and we did talk about rosiglitazone, and then all these other ones also. So that's pretty much all the medications, which included your seizure medications, all your rest of your insulins, and a prototype from each of the classifications of anti-diabetic meds. Please go over these. You really need to learn as a nurse what the onset, the peak, and the duration of your insulins are. I promise when you get to clinicals, you will be asked this information by your instructor anytime you're going to administer insulin. Now, as you all know, this insulin in the vial, or insulin in the vial, is usually stated on the vial whether or not it's a U100, and if it is, that particular insulin has to be used with U100 syringes. We administer insulin subcutaneous route, and we various times will change different locations of how we administer insulin, and many times too, when your patient's been a diabetic for many years, we may want to have the patient participate in their administration of their insulins because they've been doing it at home. You know, look at their skin, look at the different sites, make sure that we don't see some of the adverse reactions happen to the skin when the person is using the same site for their insulin administration. Make sure that they're you know, withdrawing the medication under aseptic technique, making sure that they're using one syringe for one dosage, that they're not reusing syringes, because we know how the needle can start to get blunt and it can actually break off if they're using it for more than one injection. Make sure that they're reading the calibrations on the syringe correctly. So this is a great time for somebody that's been a diabetic for a while to kind of see how much they understand about their medication and about the equipment that they use to give their injections with. Make sure that they are self-testing. You know, if they have an insulin pump, you may want to kind of assess what the trend is, what their blood sugars have been. A lot of times people really get lax and not really as compliant with their diet and even the self-testing, because some of the equipment, the strips and the machines and all that stuff are very expensive. So patients try to save money, and I understand that completely, but it really is about their life. And diabetes is one chronic disease that you want to try to be as compliant as you possibly can to avoid a lot of the complications. And I'm sure your lecture instructor for Nursing 122 will really state and point out many of these important aspects of diabetic teaching, and you know, really helping patients as well as families learn about how to keep their diabetes in control to really slow down the progression or the possibility of all the complications that go with it. So thank you for your attention, and if you have any questions about anything, please let me know. Enjoy your day.